because I want to. Oh, did you guys have Occupy? Did Occupy come here? So this was Occupy Boston. It turned out Occupy came in and sat right in the middle of Dewey Square where many of our folks were sleeping outside. And all of a sudden, it turned people that were sort of on the fringe of society, all of a sudden for this sort of brief shining moment, they were part of this community where they all had a job and they were all treated equally. This is, Paul is one of our very wild and histrionic patients who's now part of the security for Occupy Boston. This is Shauna, who is part of the food service team. You know, and I've never known Shauna to do anything. You know, we've never seen most of these folks get sober, but they had a job, they had a part of that, a role, they got sober, they did really well. And what we found is that for that brief period before things kind of fell apart, you could see a society where things could work a little differently. Now, of course, the Occupy movement had its issues and went on. This is, we're not always so successful. This is a woman whose name is Vera, and she's been out about as long as I can. We've tried to commit her several times. Each time we commit her, she's let out, and she comes right back out. But, what we have found is that there's still people that even after 20 years we haven't been able to win over. But so I don't want to paint this as a Pollyanna kind of picture. There's still there's folks out there whose thought disorders are really tough to get through. And I worry a lot about whether we're doing the right thing with them. To anchor all this, by the way, and this is where I would urge you to think about, these are sick people who are struggling with major medical issues, and I could go over that, lots and lots of substance abuse and mental health issues. And we really need, you know, they're in and out of the hospital all the time, legitimately sometimes with their medical problems. It's not that I'm trying to say it's overuse in that sense. So we needed to be sure we had a place where we could see people in the hospital, and we started a clinic about 12 years ago at Mass General for the street folks. We have a clinic there every day of the week, which is our homeless clinic, but on Thursdays, we converted it into a clinic where we would have soup and sandwiches and you know, pastries and stuff for people in the waiting room. It's a separate waiting room. And then we give people meal vouchers so they could go and have a meal while they're waiting to be seen. And then we have volunteers and our nurses there. And then we see people in the clinic, and it's actually really fabulous. This is Mary Ann, who's our nurse doing triage. She'll do triage of this thing. And I always show this picture. I don't know if you can appreciate it. After I took it and I was showing it one day, one of the medical students pointed out to me that somebody's sleeping under the table. So you get the flavor for the clinic can be pretty wild and wonderful. This is when Jill, our physician assistant, was getting her MPH, her master's in public health. She's now working on her doctorate and actually studying exactly the stuff I'm talking to you about. But the clinic has a great flavor to it. We thought no one would ever come. Okay, it's a street clinic. The hospital's still cherry about whether this is a good thing to do or not, because you can imagine what it's like to bring everybody in. But we see about 100 to 120 people every Thursday, street folks who will come in. And when you ask them, is it because it's Mass General, you know, which is a pretty good hospital, they don't care about the hospital. What we found about that is, if it was Jill who saw them outside and says, come see me at the clinic on Thursday, they'll come to see Jill, they'll come to see me, or they'll come to see our psychiatrist. So it's, once again, it's the relationship that goes on. So we found that where we thought no one would come, we can't handle the numbers of people coming in now. We've been working on that. But it's also great, we have a lot of students, and it's just a kind of a fun atmosphere. Here's our psychiatrist. So Jim Bonner is our full-time psychiatrist on our team, and he doesn't have a room on Thursdays. And so what he started doing was seeing people in the cafeteria over a cup of coffee. And this is his office now. It's Mass General's main cafeteria. He hated this at first, thought it was not going to be private and confidential and everything else, but it turns out it's what folks really like, and he now loves it. People will talk to him about certain things. It can be a 5-minute visit or a 20-minute visit. It doesn't always have to be those 45-minute or 50-minute visits like that. And he feels he's pretty seasoned. He's now just turned 70, and he used to run mental health clinics all over the country. He worked in New Zealand for a while, and he's in heaven now because it's a place, it's a way to get to people that he was never able to get to before. And he does our housing visits as well, so I'll show you that in a moment. I have no idea what time it is, by the way. Am I over time here? So I have like 5 minutes or something? Okay, we done?
No, keep going.
Okay. Am I bored? If I'm boring you, can stop me right here, because I'm dreading fear of crossing an ocean just to bore you here. The stories, though, what I would flag to you is that if people have been outside, we have a challenge in our program. If somebody's been outside for a year or longer, okay, they have suffered unspeakable trauma and are going through things that are just horrible. There's no one who just stays outside. I've asked any of our staff to show me someone who they think just happened to stay. I want to stay outside, and that's the only reason they're out there. So these are two guys who were written off by the system. They come in. Greg is on the left. He lived under a bridge from the time he was 14. He looked like a troublemaker because he has a stutter, and every time people made fun of him for his stutter, he would beat them up because he's kind of a big, strapping kid. And he was always in trouble with stuff. And as I got to know him under the bridge, and I could sit and get through the stutter, it turned out he couldn't read or write. He had never had a chance to do that. When we did formal testing, his IQ was about 50, just below 50, so he's, really had a developmental disability. And he had grown up homeless. He'd never had dinner at a table. He'd never, read a book, never done any of the things that most of us are used to. But he was written off as just a troublemaker. So we realized as we got to know him, and it took 10 years to figure that out, okay? So it was not an early, easy thing to do. His friend Billy on the right there was in and out of jail, also a troublemaker. But Billy had a fascinating story. I got to really like this guy, even though he did his best to really piss you off. He would always try to find out what would make you angry. But he's smiling there because what happened when he was 5 years old, he was in the race riots that were in Boston. He was 5 and he was in a front yard, and somebody poured gasoline all over him and set him on fire. So what you can't tell here is that everything below his neck is burned. And he grew up that way. He can't read or write either. He has AIDS, he has diabetes, he's got all sorts of heart problems, and he's been trying to struggle on the streets for 25 years. And nobody pays any attention to what's beyond what his persona is, which is really trying to make you angry. So the cops can't stand him, it's like that kind of stuff. But when you get through all of that, which took us years to get through, you realize that these are two guys that I would have said, why don't they just get a job? And in fact, they're profoundly disabled. And both of them are needed, they both are followed by Dr. Bonner for their psych issues. We've got them into their HIV and diabetes care and stuff, but it's really tough. And then this is a picture I just want to share with you because the continuity issue always comes back to us. How do you stick with people? Because the longer you know people, the more you get to know them better. But this is a street couple that Brad is on the left, who was a Green Beret in Vietnam. He was a highly decorated Green Beret. And Charles is on the right, much younger than Charles, but they hooked up, and Brad somehow, whatever fell apart in his story, he ended up on the streets. And Charles was kind of his partner. And I took this picture just because Charles had been the first person I took care of who had HIV, but he was a long-term non-progressive. He, with no medication, he managed his HIV control. There's very few people that do that, about 5 to 8%. And he was the only one I knew on the street. And he was convinced he was okay because he was managing his diet and everything else. And about a year or 2 years ago, when I took this picture, all of a sudden his CD4 count started dropping after 25 years of having AIDS or HIV. And I told him, you've got to take the medicine. It's life-saving, it's life-preserving. And he was convinced that he could take care of it with diet, he wouldn't take it. And about 2 weeks after I took that picture, he came in with pneumocystis pneumonia and died from his AIDS because everything had plummeted. Brad, who by that time we had housed them both, Brad, who was his partner, was devastated, started losing a lot of weight. We thought he was grieving. And we went to see him at home maybe about 3 months after this picture was taken. He had lost tons of weight, did a chest x-ray, and he had a big, huge tumor that had gone metastatic to his brain and to his spine, and he was dead within about 6 months of the time I took that picture. And I was looking through my archives because we were trying to do a ceremony for him, and this is a picture I took 25 years before when they were at Long Island Shelter, that shelter I showed you in the beginning, as a young couple. And Brad, they were both at this time, and the reason I cherish the picture is they decided, this is really gutsy in the shelter system of Boston in 1985, to get married. And shelters are pretty rough and tough places, and getting married, especially when you're a Green Beret from Vietnam, was a real gutsy thing to do. But they stuck together for 25 years, when you think about that. So that street couple, for whatever it was, and their stories are complicated and devastating in many ways, but it was a love story of remarkable, and actually I've never seen anything quite like it. It was really remarkable. Just another quick story of what you learn as you get further into this. And I hope you're hearing them unabashedly making an appeal for why it's important to get out. And if you stay in, you're going to miss a lot of stuff. And I think it's the clinicians who have to get out. I think we're learning for a small segment of the population. And I know when we talk to our Medicaid department, they will always say 5% of the people in Medicaid are using up 50% of the thing. And these are the folks that are in that 5%. They don't fit into the usual system that we have at Mass General and Boston Medical Center. They need some special stuff. Now, what the right thing is, I don't know, but I think part of it is getting everybody to work together and get out to where they are, but come out as a unified, integrated team, and co-located. I think you've got to do it co-located. But anyway, this is a young couple that was living under a tunnel in Boston, right on a Copley Square. And I actually been doing street work for about 15 years before I knew this tunnel existed. But there's the Mass Pike goes underground, and then there's a MBTA, which is our transport, and then an Amtrak line. So there's 3 sets of tunnels. And there are a bunch of people who live under there, which I didn't know about, including this couple. And Katie Katie is 18 there, and she's pregnant with her first child. They have a very complicated relationship, which is based on cocaine. This is where they live. So if you go down this little tunnel, head down there, and this is what throwing a lot of light at. They lived about 40 feet underground on this little platform there, which is where they were. And so we had to go down and find them. Anyway, she came in. We convinced her to come into McGinnis House because she really was her first baby. She was 6 months pregnant, had been using cocaine every day, decided she'd come in and try to make sure the baby could be born not addicted. So she stayed at McGinnis House and did really well. She came with her boyfriend, Bo. And then she delivered her baby the night before I took this picture and called and said, would I please come and take a picture of her family? Her mom was there, her grandmother was there. So I went over and I took this picture for her. But before I took the picture, her mother, who's on the left there, came over and gave me a big hug, because I used to take care of her when she lived on the streets of South Boston back in the 1990s, early 1990s. And then her grandmother came over and said, you wouldn't recognize me because I dyed my hair, and I didn't recognize her. But I used to take care of her in the mid-1980s when she lived on the streets of the north end of Boston. So I was looking at this. This is 4 generations of homelessness, okay? And they managed to keep, in touch with one another. But as I find this picture priceless, Katie, she has this picture and keeps it, we're with her all the time. The downside is that her boyfriend came over, and this is when he wanted a family portrait at the same time, and we took that picture. It was actually a beautiful, healthy little girl. And about an hour after I took that picture, she gave the baby up, and they both went back to the tunnel. And 6 months later, Bo, the boyfriend, was stabbed to death on Boylston Street. So it was like this Katie, after all that she went through, lost her boyfriend, lost the baby, and is now still on the streets. We still keep trying to coax her in. She's back pretty well addicted to cocaine. I think in those circumstances, we realize we're working really upstream. This is a real societal problem. This is a woman whose problems go back generations, and we have to really change some of the ways we're approaching stuff there. So going back to these guys were part of that 119 people that we decided we'd watch over time, and this is what a lot of this is what I would, even though we haven't, Felicity had asked this, but the validation of the vulnerability index is being done by some folks at San Francisco. We were nervous because we did chart reviews. We didn't do asking people, so we didn't know, how to quite validate that. But just to give you what happened is, we followed these 119 people for 12 years on the streets, and half of them, okay, their average age at the time we enrolled them was in the mid-40s. Half of them are dead right now. And these are street folks, 119 street folks, who we followed really carefully. If you notice, we lost about 7 of them to follow-up, so some of those maybe did, but we know half are dead, and we lost only 7 to follow-up. So it is, we brought that to all of our friends at the schools of public health at Harvard and BU, and that's the highest crude mortality rate we know of any subgroup in America. And I would wager it's what you're going to find here in any of your streets. This group is really vulnerable. And I'm guessing you could almost get rid of the vulnerability index and say anybody who's been sleeping out there for 6 months or longer is vulnerable. Okay, it just is going to be that way, I think, as we learn more and more. Starting with the vulnerability index, or any tool, I think, is a way to get attention to something which is, I think, going to turn out to be, like for us as for you, a public health emergency that really needs to be addressed. Why did they die? This is what fascinates us, and we're looking into this a lot more. The most common cause of death, which you would never believe, is cancer. Okay, so people aren't dying of the things we used to think they were dying of, hypothermia and things like that, and assault. They're dying of medical problems that are complicated by their substance abuse and mental health issues and ought to be treated, or to be prevented, or at least taken care of. So this is what we've learned. I can tell you in a minute about what we're going on. But this statistic goes way back a long time, but that same group of people, the 119, had 18,000 emergency room visits in a 5-year period. Okay, so that is what became the hospital clarion call. So the hospitals in Boston had to accept that this small group of people, who represent less than 0.05% of Medicaid, was using about 10% of the emergency room visits in all of Massachusetts, okay? So this is a population that's worth spending some time and effort on, And all of this, by the way, I hope you could, we were looking at and saying, you know, the truth is, all that stuff we were doing that I'm bragging about and saying we're really good at going out there, without getting people housed, we're probably not going to be able to change much of what's going on. It's too overwhelming. So what we've been doing is we did what I hope you will do, is realize that as you get to know people outside, and you can take time doing that, as more and more of them get housed through these wonderful low threshold supportive housing programs, bringing the services that we could bring to them outside to them in their home is now crucial. And if you look, this is a stupid little thing I wanted to show you, but our team, which is a street team, I didn't believe it, you saw the team ago, now does, and this is part of what we do, we spend half our time on the street now, but we did over 1,000 home visits last year in addition to being out in the street. And here's what happens, it's really fabulous. So this is John, who's standing up, and he was found right in this dumpster behind, right near where the Boston Celtics play, called Boston Garden, with a body temperature of 72 degrees Fahrenheit, which is beyond comprehension, in January a few years ago. Went to Mass General, went on cardiopulmonary bypass. We brought him to McGinnis House, and then he got housed. This is the same guy housed with we will always work as, we don't do housing in our program, we do the medical and mental health and services, and we work with the outreach workers from the housing things, and this is the outreach worker with them. And we stuck with him, he was housed, he did great, he did no more heavy duty. That episode at Mass General we looked at cost $28,000 for the treatment for Iran. I lost the other, here he is. So, and then we followed him over time, and it turns out he was sick. This is cirrhosis, and he's now, we stuck with him for the last 10 years as his cirrhosis got stabilized and then got worse, and he finally died this week. But it was an opportunity for us to follow him from way outside into housing and then to continue on. And when we talk to our consumer board, because we're a homeless program, should we be doing home visits or not? Because once people are home, a house, should we be doing that? And we had to kind of change the way we were thinking. Our board of directors, and we went to our consumer board, really, sort of pointed the finger at us. Said, look, if you've been our medical home or the place where we get care for the last 20 years, and now all of a sudden I get an apartment, you're going to tell me you're going to abandon us and make us go see somebody else? So we got stuck now having a mandate from our board of directors to figure out how to go and continue to take care of anyone who's placed in housing who wants us to continue to follow. And it gets really interesting. This is a guy who lived in a box, would not go in because he wouldn't give his name, finally got this apartment, which he keeps very spare. And he now, when we go visit him, will cook us grilled cheese sandwiches. This is Jill, who I was visiting with him that day. And he still won't tell his name, so we can't get him Social Security. We don't really know who he is. We have to figure out how to get a subsidy without a name, but he's no longer on the streets doing well. Let me skip over and tell you one last one here. So this is Chris, who was also on the street, just so you know that this isn't just whistling. This is Suzanne, who's a nurse practitioner visiting him at home. And this was Chris's hospital costs for the 4 years before we got him housed. If you can look at that, it's maybe hard to see, but he was in the ICU, in the hospital, in the emergency room. Turns out I agree, emergency room visits are they're frequent, but they're not the high cost items. And so those ICU visits really cost a fortune. But anyway, you look at that, he went from having an average of somewhere around $200,000 a year. Turns out it goes back 10 years. And over the last 2 years, he's had basically no emergency room or hospital costs. And the price of that, though, is probably 4 visits a week to go see this guy, because he's so, I can promise you this, the problems that people were struggling with and the furies that pursued him to the streets don't go away when you get them in housing. Housing gives you the platform. I have a little objection. I don't think housing is healthcare. I think it's a very important foundation for healthcare. The healthcare has to go once people get into housing, then they really need coordinated, integrated services if they're going to, this particular group, if they're going to remain in housing. I think I've got more things to tell you, but I'm worried about time. I'm done here.
I'm sure we are at that time, but I know people are quite keen to ask.
So now let me stop there, please. I could tell you more stories about housing, but I'm like plowing through and ignoring if anybody has any questions. So please, I apologize for that. If you have any questions, I'd love to answer any. And please don't make me come all this way and don't ask a question. Yes.
I'm just wondering who funds your teams?
So the question is, who funds our teams? And this is a little bit of all politics is local. In this case, what happened is we were funded by a grant from a foundation called the Robert Wood Johnson Foundation for the first 4 years. And it was a pilot grant, and now the federal government funds us the same way they fund the community health centers. So we get federal funding, so our budget is about $35 million a year, and about 80% of that comes from us being able to bill Medicare and Medicaid for what we do. All of those visits that I'm showing you, by the way, we send a bill to Medicare and Medicaid for. Okay, so when the psychiatrist sees somebody, when I see somebody, the nurse practitioner sees somebody, if it's a medically necessary visit, you can bill for it in our country, and that's how we sustain that. The psychiatrist, in all truth, though, is paid for by Mass General Hospital fully, because the hospital realized that these are the folks that were in the emergency room so long, it was worth them to pay the full-time salary of the psychiatrist to have him be seeing them outside. Okay. There are about 220 healthcare for the homeless programs like us around the country, by the way. I've squelched you, I'm really sorry, but, oh, I'm sorry,
I had
yes,
a question,
Keith.
Peter, but how are you governed? You mentioned that consumer.
It's a great, the question is, how are we governed? And it's a great question. We turned out to be unusual in that we're a freestanding healthcare for the homeless program. So we're under the tax code of what's called a charitable organization. We're 501c3 tax thing. I don't know what the code is here. But we're required by law then to have a board of directors. Half of our board of directors, because of our own thing, are consumers, and the other half are, regular board, the traditional board members that I would think about. And then we have to abide by all of the federal rules and regulations for confidentiality and all of those other things. So one of the drags of, once we were a grant funded thing, it was very great. We just had to fill out a few little forms to do that. Now we have a whole part of our program is designed to make sure we're meeting the rules and regulations and protocols and requirements of the federal government. Okay. Does that mean you can have lunch now or something like that, or no?
I had a question, Jim,
Sure.
just around, you say continuity is the name of the game, and one of the challenges here for us is we need to often refer out to other clinical services to provide that healthcare if we're supporting an individual. And in that process, many people either don't access that next step, we lose them in that next step unless we actively try and engage them into that healthcare system. I just wonder in the States, and you reflect on that in terms of integrated models and the need for multidisciplinary teams that are well integrated, what that really means, what integration should look like so that continuity of care can occur and you get the outcomes that we're after.
Could everyone hear the question, by the way, of yours? We've been struggling with this. What is the right model? Well, I can just share with you our experience. I think every time we meet, by the way, 4 times a week as a team to discuss who we're going to see today and who's most important and who's been in the emergency room. So the pressure on our team to communicate, because we look at all of us as serving a panel of patients. We all serve the same panel. It's not a different one. So our psychiatrist, his panel of patients are the same patients we take care of. So they're all ours. And that requires a lot of communication, okay? What we don't know is what's the right way to do that. What we have found is when we used to look at, you give someone an appointment, if somebody lives on the street, you give them an appointment that's longer than 2 days away, that a no-show rate was close to 95%, meaning an appointment made 2 days past now is never going to be shown up. And then everybody gets angry with them because they don't show up to the appointment. So we have these orthopedic doctors who say, don't send me anyone else. The last 5 people you sent to us didn't show up. They won't see them anymore. So we realized that failed for us, particularly for the street population, because I think life is so immediate on the street. Saying what's going to go on tomorrow, the next day, just doesn't work. At least that's our theory. So we found when the psychiatrist comes with us, he will, or I think we have the 2, really 1.5 that equivalents, but they'll see people wherever you can, or they'll say, I'll come by tomorrow and see you at Starbucks, which is a lot easier of an appointment than saying, go to the mental health center next week and see something. So we're learning that most of the care we do now for the people outside is done outside or in their homes and not in the clinics. When we started doing home visits, about 75% of the people we had seen in our clinic sites are now seen at home, and so we only do 25% of the visits. And it's just much easier. It's much better. I think the other lesson for us is, even though this is a luxury and I accept it, we would not be able to do this if Mass General didn't allow us to pay for the psychiatrist. So I'm not trying to paint an easy picture here that this is easy to do. But when you can work together with someone, if I can be seeing somebody, and they ask something, I can say, hey, Eileen, can you help? Right there, she's right here. And the person already knows Eileen, and it's not frightening in that sense. So it's not like they're going to go see somebody they've never seen before. Our folks do terrible when you say, go see a specialist who may or may not be someone they've usually someone they've never seen before. We generally don't do well with that. what we do now is have the specialists come to us at McGinnis House. We'll bring people over to McGinnis House where they feel comfortable and try to get the specialist to come to us. That's almost impossible most of the time, I think, around, but it works. So that's the goal we're looking toward now. Does that answer the question, Kim? Okay. Yes.
I just wondered, do you still have your national conference or your annual conference of street medicine? And I know when I heard about it, I thought what a brilliant opportunity to bring about some change of skill and attitude in the or give medicos an opportunity to hear about your work and get involved. And I'm wondering if you could tell us a bit about it so that people here might consider going.
I'd be happy to. The question is about, there is a international street medicine conference which occurs once a year that was actually started by a really interesting doc named Jim Withers, who's been doing street medicine for the last 15 years or so in Pittsburgh. And he started gathering people. It turns out there's a lot of commonality for street folks. So when the conference occurs, and it's in a different city each year, there's people from India, people from Africa, people from Puerto Rico, South America, and Europe who come, along with Canada and the US. Just a bunch of people who share in doing street work. And it is a huge variety of approaches, which is really fun because you can pick and choose things from different things. And it's all people that are like-minded, they're all trying to do it. So it's actually really fun. I'm sorry I don't know but it's streetmedicine.org is how if you get on that and you can look and see what's going on. And it's great fun. The other conference that's been great fun for us, and many of you have gone to, is the National Healthcare for the Homeless Conference, which is the healthcare focused conference, and then the National Alliance to End Homelessness, which is the more policy one. Those tend to be the three conferences that we find the most sustenance in when we go, and you find people that you really can learn a lot from. And I hope, the other thing I probably should have said in full disclosure, we have a weird country. We do not recognize a right to health care, which is unbelievably embarrassing to us. However, in Massachusetts, where I come from, the state has adopted a right to health care approach, and they have incrementally made it so that virtually everybody in our state, 98% of everybody in the state of Massachusetts, has insurance now. And that healthcare model is the prototype for the Obama new healthcare thing. Interesting for those of you who follow our politics, it was a healthcare plan that was started by Governor Romney when he was there, who's now running against Obama and running against his own healthcare plan, but that's another whole story. But when we see people on the streets, this is important so you know that the luxury we have is that Massachusetts insured everybody who is below 125% of poverty now has Medicaid. And you don't have to show disability, you just have to show poverty. And if anything we know, our folks are the most impoverished people we know in America. So everybody that I've shown you there has no money. The best they might have is a Social Security check, which still is below poverty level. So they all have insurance. And once everybody has insurance, then the doctor visits, the nurse practitioner visits, the PA visits, the licensed social worker, all of those you can capture income from or revenue from. So you can begin to construct at least the nucleus of an integrated team as people have insurance. Now, I don't understand the insurance exactly here in Australia, so you'd have to figure that out yourselves, but that was the breakthrough for us. Once we had, basically 90% of the people we take care of have insurance, we can sustain our outreach program on its income. So we don't rely on any grants anymore other than the one Master Nolan to do, if that's sort of hitting with your question. Okay.
Pharmaceuticals covered under insurance.
Yes, what Medicaid, it turns out Medicaid, I never believed this because I lived in a hospital for so long, but I hate it when our folks get on, in our country, you can have Medicare, which covers hospitals, hospitalization and doctor visits, but not nursing home and not very much of pharmacy. So Medicare is a drag because it'll ask people for a lot of money, which they don't have. But Medicaid, which is the poor, Medicare comes if you're 65 or if you're disabled and you have been working, we give people Medicare. But Medicaid comes to people who are disabled and have no money. Or now, if you're poor, you just get it. And Medicaid covers, in Massachusetts and many states, covers basically everything, except it covers everything. So if you wanted to have a health insurance in our country, you want Medicaid. Now the downside is not all doctors will take Medicaid, but all the hospitals do. And I sort of shortchange a little bit the importance of hospitals in this, but our folks, you know, even though we're doing all this, we're constantly, we have, like right now, I've been getting my emails, we have 9 people admitted under the wards of Mass General since I came here. So 9 of our folks have been admitted. So we have to have an active inpatient service to take care of them. And Medicaid covers all of that. And for our McGinnis House, Medicaid actually covers the respite program, not Medicare. So that's kind of crazy. So I love it. I'm sorry, I should have said that. When I know somebody's on Medicaid, then we've got lots of latitude. When it's Medicare, we have to fudge a little bit.
So your community teams then get involved when you've got an inpatient, someone's an inpatient, and the community teams are part of the discharge planning?
Yeah, well, you know how we've fudged that? This is another local thing. The very beginning community folks made all of us as doctors stay part of the hospital. So I have to have an appointment in Mass General and be able to take care of my own patients. So what they wanted to do is if I see somebody under a bridge, they're already a Mass General patient because I'm a Mass General doctor. So yes, we get, you know, when one of our patients gets involved, I'm the doctor, or our team is the team involved in the discharge planning, you know, which is fabulous. It's so fabulous because so much happens. When our folks go to another hospital and they have a major thing going on and we're not involved, they come back to us and so much goes wrong because we didn't understand what had happened. It's a nightmare. So I am so big on making sure we're pushing hospitals to stay involved. These are high cost folks to the hospitals. It's way in their interest to work with us to keep them out of the hospital. So when they come in, work with us to make sure we all are on the same page for that. It's a big important thing. Dan, I'm sorry.
Thanks for your presentation. I just wanted to give some more information about risks, like risks to staff, and how you guys might manage that.
I'm sorry, the risk to?
Staff.
To staff. I'm sorry.
Yeah.
I'm so sorry. It's a big issue. Safety is an issue. So, for example, when we do home visits, and this is an added challenge, we always go with 2 people. We always go with a medical person and a mental health person, but we never go alone because of safety issues. But that puts the pressure on your team to be going 2 by 2 rather than, you know, you could divide up and have, you know, 5 people each going to a home visit. That's nice, but if you need 2 and 2, it's inefficient. But we do that for safety. Interestingly, I've been doing the van for 26 years now, and been on the streets, and none of our street team has yet had a major incident. You know, we've been near some incidents, but never had it. But I say that, knocking on wood, because, you know, it is volatile out there. It's something, you know, safety is an issue, and everybody has to be primed for it. So we visit that every 6 months. We talk about safety issues and what we would do and all that. But so far, knock on wood, that has not been a big issue. And the longer you know someone, the less likely the violence happens. It's usually those people you're meeting for the first or second time that are much, you know, it's a little scary. As you get to know people, you understand it. But it's an issue. I think everybody has to face that. Yeah, Dan.
I'm a psychiatrist in a community training team. I work with former patients in Boston, catchment area. I served there, and I now work with formerly homeless patients in Brisbane. One of the biggest issues we have is that I do home-based care, and I go to people's homes in Boston, and I do it in Brisbane, and I can't find a medical doctor, an internist, to come with me. So we actually don't have that integration of care. So when they transfer from your really good quality care in Boston to a mental health team, they lose a lot of the medical care, and that's a huge deficit. What can we do to help reach that integration for patients who are now housed?
That's a great question. Our struggle with that has been how to get the Department of Mental Health, who's responsible for most of these folks, to play ball with us, because when somebody gets admitted to the DMH, as you would know, the center, then confidentiality issues happen, and they don't even tell us what's going on. We could notice somebody's disappeared from the street and have no idea where they are for 6 months and find out they've been in one of our local mental health hospitals, and we didn't even know it, even though I take care of their diabetes, you know, or something like that. So we're still struggling with that. The breakthrough we've had is that both Eileen and Jim Bonner, our 2 psychiatrists, are now DMH qualified and credentialed. So they have full access to the DMH system and are considered inside the DMH system. So now if we've lost somebody, they can simply look on the EMR and see if they're anywhere in the statewide system. That's helped a lot. But I think once people are inpatient, we find that in the DMH system, we still struggle with getting them to share with us what's going on. And I suspect we do the same thing when they come into medical care. We're thinking they're in the hospital, but do I think to call their outside psychiatrist? Probably not. And so we still need to work on that.
What about when they transition from homelessness to housing?
Mm-hmm.
So that, you know, when the homeless services are not providing services and they're stably housed, how do we get the medical and mental health integrated then?
That's The only well, I think we're trying to struggle with that because we're looking at just our small population of rough sleepers, and since they've been our primary care patients, like all of the rough sleepers are basically who we take care of. So we follow them into housing, and all of the housing agencies love that because we'll just follow them in and take care of them. So it takes the burden off the housing agency for that particular supportive services. So we're now trying to figure out how do you do that more generically, especially for people who might not have been in our system and now go into housing. Should we be working with all of the housing things to set up teams to just do that, which I think we're going to learn from you guys. I think that's what you should be doing, and somebody should be doing, figuring out how these supportive services are critical. I didn't show you the data. We have lots of data on about 350 of our long-term street folks have been housed over the last 7 years, and we can tell you what's happened to all of them, and how many times they moved to avoid eviction, and what's been involved in the moves, and what kind of problems have come up. And it requires a ton of service once they get in for this particular population that needs to be really on-site, integrated medical and mental health services. So we got to work on that. We don't have the answer. I want to tell you one thing though before I ask. What I didn't say, and Dan, you would appreciate this, is there are so many people, there were many, many people outside who were very psychotic, and we have a very high bar for committing someone. We respect civil liberties. So we struggle all the time with where is that limit, and it's been so helpful to have the psychiatrist out with us to help us decide that. And I don't know if I've mentioned this to you before, but my sort of emblazoned terrible memory was this one woman who was outside for years, 10 years, and she would sort of keep herself covered in feces and urine just to keep you away. And it was always smelling. She lived in a doorway. She would snarl at people and just didn't want to talk to anyone. And on the van, our goal is to win trust. So we kept trying to leave her sandwiches, leave her a blanket. And after about 5 years, she started saying thank you for the sandwiches, and we thought we were doing a great job. We're finally breaking through. And then one day, she lost it during the daytime, and she was committed by the police. She went to a hospital, got on medication, did really well, got housed, and now she's on the board of one of the shelters. And I saw her. Didn't know what had happened to her, and I saw her, and it was like I've known this woman, covered in stuff for years. And I said, God, you look great. You're on the board. That's really fabulous. She looked at me and she goes, you bastard, you left me out there for 10 years. And I was like frozen. So, her appeal was, why do you let us live like that? And then the other side is, they have the right to do that, and I don't know how to. So the reason I think it'd be great to get people out is that issue comes up more all the time. I have tons of stories like that. You probably don't have them too, Dan. Anyway, I know I'm way over time here. Thank you very much, by the way, and I look forward to the rest of the day here. Okay? Sorry, I'm way over time.
Very quick, thank you so much, Jim, for fantastic, and you didn't bore us for a second, yes, but gave us a lot of insight into what might be possible, which I think is fantastic for us to take forward this afternoon. So we have lunch now at the back there till 1:15. During the lunch break, there will be a YouTube video showing on the screen if you would like to have a look at some of the local stories from Brisbane. And the other thing is, we are taking some photographs, and as Jim said, we like to have photographs so we can identify people, and so we can use them. Potentially, they'll be used by MICRA and other organisations to perhaps put in newsletters or the media or on internet sites. If you've got any issue with having your photograph taken during the day, please, or video, please see Helen to let her know, and we'll make sure that your photographs aren't included in anything. So, thank you. Thanks.
Take a photo of those who don't want to be there. Take a photo. Thank you so much.
I'm nervous
It was
with that,
amazing.
so can I give you that?
Amazing insight. Thank you so much. James?
That was great.
Yeah, I'd love to make a film about you, but that's somebody already doing it, so. So.
No, I realised when it I know, and I keep trying to. Were you trying to get some over there? Oh, you just go up and do it.
Sorry, can I just take a shot of Michael Projects? Can you get some people out of the shot, please?
Out of the shot of the.
Yeah, like a Kim shot.
People?
Just that. Just, yeah. Yeah.
Sorry.
It's fine. Okay. Oh, sorry, I'll do it again.
We're making another version of which is that message about. So we're getting extra footage.